Thank you all for coming. It's a pleasure for the department to be able to have this opportunity to interact with you all and share with you some of our changes within the facility here at licensing and what's happening within our department. I know we went and made some more copies of documents, so those of you who didn't get all of them, we'll have them sitting over there and you can have them at the end or at break. Let me just run through what you should have available to you. You should have, first of all, the new organizational chart. And this is a new organizational chart in how the Department of Licensing is now organized. And Dr. Kara Christ is now our Assistant Director, and she is responsible for all of licensing. And then you can go down through and you can see all of the individuals that are responsible here as we move forward. As a dialysis facility, you are in the branch of healthcare institution licensing, which is the medical branch. And in that medical branch, you'll see that I'm Connie Belden, and I'm the acting bureau chief for the medical licensing. Kathy McCanna is our branch chief for medical licensing. And then we have a second branch chief, which is Tom Salo, who is responsible for all central services and all non-healthcare licensed entities that we have within the organization. So you'll be able to see this. These are good names to have as references. So if you have questions or any thoughts in the future, or I make sure that you reference this. Then you have a one-page document, which is looks like this, which is a crosswalk of all the rule integration and what we've done, and we'll talk about the rule integration as we move forward. But this is available on the website as well. So please use it to your advantage, and we'll talk about the website as well. Then you have the rules. You should have a copy of the rules. And you'll notice that this is Article 10, Outpatient Treatment Centers. The rules that were separated into a separate article for dialysis no longer exists. So dialysis is integrated into Article 9, Chapter 10, Article 10. So when you look and you reference up to the Secretary of State in the future, you're going to look for Chapter 10, Article 10. So dialysis is integrated into these rules. And then as an assistive tool, what we have put together for you is an Excel spreadsheet. And we'll put this on the website so you'll have an electronic copy of this as well. But it's just a tool for you to use. It has all of the rules that are identified for state licensing rules in the far right-hand column. Then it has the specifics under each of those rules, and then it has compliance or non-compliance. And it's just for you to use as a checklist as you go through your facility. You look at your operations and try to determine, are you in compliance with these specific rules, or are you not in compliance, and where are your opportunities? And the reason we want you to do this is because we want to be able to come into each of your facilities and find no deficiencies. So if you have this tool and can use it as part of your monitoring and your evaluation within your organization, we think it will be helpful. Sometimes it's difficult to read the narrative, and this might be an easy tool for you to use as a check mark. So those are the handouts that you should have. In addition, you should have a card. It looks like a business card that gives you the website in which you can go on and find all of the rules that are being integrated and changed. So keep that as a resource. And you will also find on that website, you're going to find some other resources that we'll talk about here in a little bit. Okay? All right. Now, this is our strategic priorities for the department. And we wanted to share this with you because this really gives the foundation for why we're here today looking at rules and the reorganization of rules. Our leadership, which is Will Humble, who's our director, and you'll find his name on the organizational chart, has felt that licensing really is a public health division of the Department of Health Services. So you will see in our letterhead changing to public health licensing because he feels that we have a key role in the public health in Arizona and not just a regulatory component as we move forward with integration of our rules and the departments. So the integration is not only integration of the rules, but it's integration within the department, utilizing all of the department public health resources. So when we look at our public health resources, we're looking at our EPI team, and some of you maybe have had the opportunity to have some of our epidemiologists come out to your facilities and provide some technical assistance. They are available. We want to be able to provide that service to each of you as you feel a need to have an outside look, maybe from a non-regulatory perspective, but from an epidemiology perspective as you move forward. We also have our TB team. We have our smoke-free tobacco team, so if any of you are doing programs within, or you have patient challenges, or you have care plans that integrate with that, certainly let us know. And we also have behavioral health, which is a strong behavioral health division within the department. So our integration is integrating licensing into public health, integrating public health within the community to improve the services and care that's being provided within Arizona. And then also integration across the country. You'll see Mr. Humble has led us into various areas of looking at best practices and other regulatory agencies across the country. So, and Dr. Christ is really mirroring that as she brings that leadership down within the Division of Licensing. So as you can see, these are the strategic plans as you move across the process there. When we looked at our first step with integration, we talked about our rules. And as you know, we have been very siloed in our rules approach. And the legislature looked at, and their first initiative was integrating behavioral health services into the physical medicine. As you may or may not know, that behavioral health has been a separate licensed division. So from licensing perspective, we treated licensing behavioral health facilities different from licensing physical medicine facilities. So as we looked at that and looked at what's occurring within the country as well as within Arizona, that it was really important to integrate those services together. So the state legislature made the decision that they would direct us to integrate our rules and reorganize our programs. And when you look at the organizational chart that I handed out to you, you will see that behavioral health is no longer an independent program within the Department of Health Services. It's integrated into medical licensing or integrated into residential. So behavioral health services become a part of all of us as to what we do today. And many of you, I know, have had those challenges within your facilities. What do you do with an individual patient who may be acting out or changing and have some behavioral needs? And so we're hoping that that will help as we move forward with integration to have those resources available to meet those needs. The other components was to really reduce the monetary and regulatory costs to the providers, and also the efficiency within the Department of Health Services and streamlining the regulatory process. So when you look at what we're going to talk today about with the rules, you'll see that there are some changes. We're streamlining them. They're consistent across the board with all provider types. So depending on what services you're providing, whether you're an outpatient treatment center that's providing clinic services or a dialysis center providing very intense dialysis care, medical services, and nursing services, some of the regulations are going to be the same consistently as they relate to overall regulatory compliance. As I talked about, the new integrated rules are going to focus on health and safety. Some of the rules you're going to hear about today do not necessarily, you might ask yourself the question, is this health and safety? Some of them are technical types of expectations that we expect you to function and perform. Where you're going to see the focus on health and safety is in the survey process. The survey process is going to focus definitely on health and safety regulatory issues and rules. So if there is a technical rule, we're going to give you some technical assistance that you're in non-compliance with that rule. You'll have an opportunity to improve. Now, I will say if you continue to be in non-compliance with those technical components, you may wind up with a citation. But otherwise, we're going to focus on the health and safety. What's most important in the services that you're providing as it relates to the care to patients. And we talked about consistency across the board, streamlining, integration, and we also will be doing 5-year reports as we move forward with this. The other opportunity that we're going to have with this rule package that's going through is they are effective October 1, 2013. They were posted July 1, 2013, so that the public would have an opportunity to review these rules from July until now for implementation in October 1. So when we implement these in October 1, we have some data elements in place right now to evaluate compliance and also understanding of the rules between now and March. We're going to be looking at those. We're going to ask for public comment between now and March and be able to identify what rules are really significant, and maybe there's some that are not so significant. So I encourage you to stay in touch with us on the website, making sure that you're understanding what's available to you and your rules, to make sure that you give us your feedback as we move forward. And then we'll be collecting data from the survey process. We'll be able to make some changes then in March to the rules, and then they will actually be finalized April 1, 2014. Oh, it's 2014 already. So we've talked about most of everything on this slide. We're going to go on to the next slide, and I've already talked about the timeline, but this gives you the information as it relates to the timeline. Again, we submitted these to the Secretary of State on June 28th. When you go on the website, you're going to find that it'll say unofficial rules, and that's because they're not official until the Secretary of State posts them to the Secretary of State site. However, they are the rules that will be effective October 1. So when it says unofficial, don't be scared away. Go ahead, print them off, view them however you do in your processes within your organization, and make sure that you understand those. And they are exactly what I've handed out for you today. What it does do is give some flexibility to policies and procedures. You're going to see in the rules that no longer are we prescriptive in some areas, that it's up to you as an organization to determine what your policies and procedures are for certain elements within the rules. It also lets you determine what your staffing needs are based on some criteria, and also training within your own organization as it relates to new employees orientation programs and your ongoing in-service education programs. This is the crosswalk that I gave you. This is the source. When you go on the website, you'll be able to see this component here, and it gives you all of the resources that we have. It's also going to give you the available to all of the taped training programs that we've had made available as we move forward with this. All of the PowerPoints will be on site, the video tape presentations, as well as any updates to any of the rules, and we'll also be putting in a frequently asked question component. So at the end of our session today, we'll have an opportunity to ask questions. We'll record those questions, and then we will respond back in writing to those questions on the website as well as verbally today. This is the handout that you have that gives you the crosswalk as to how the integration is occurring with various facilities throughout the licensing division. And here's the website, which you have on your cards. And then when you look at what we're going to be talking about today with Article 10, you're going to have rule content changes, definition changes. There's going to be some additions that you may not have had in the past in your current rules. There's some interpretation changes, and most importantly, your article number has changed. For those of you who aren't aware of how the rules are developed and what happens within the department as it relates to the rules, the law is the Arizona Revised Statutes. Your state legislatures determine what the law is in Arizona, and the governor signs over those laws. Those laws are stated in the Arizona Revised Statutes, and then once the law is integrated, then it's up to the department to put rules to that. So the rules are really coincide with the Arizona Revised Statutes. So first of all, we have the law, then we have the rules that comply with the law. So we can't have any rules that there's not an Arizona revised statute for. So all the rules that you're going to see today are based upon the Arizona revised statutes. So the emphasis here is if you have a non-compliance in a rule, you really have non-compliance with the law. So you want to make sure that that's why we want to move forward with a lot of technical assistance so that you're not put in that position to be in non-compliance. Now, just one moment here. I'm going to transition over to a Word document. So we're moving out of a PowerPoint presentation and we're going to go into a Word document, which will be a scrolling document for you, because we wanted to make sure that we did not change anything in moving information over into a PowerPoint presentation so that you have the actual rules. What you're going to be seeing is the actual rules if we scroll through this. So we're going to start with the provider responsibility. And what we're going to talk about today, because as you can see, the rules are about 50 pages long. We're not going to go through every single rule today. We're going to skip through some because we're really focused on what you're doing within your services as an entity providing dialysis services. So it's going to be your responsibility to review those rules, make sure that you're in compliance with all of those rules as you move forward. But we will highlight things for you as to what may be changed and or what we find non-compliance with that we want you to focus on in the future. This is another website that you can use to get to the rules, which is a little bit shorter process to move through the rules, but it will not get you to all the other resources, the crosswalks, the PowerPoint presentations, and information. We just wanted to give you a couple options as you move forward with that. And again, this will be posted. You don't have copies of this particular presentation, but we can give you that information at the end if you would like it. So first of all, I'm going to start with Article 1. I've emphasized that you're going to be transitioning to Article 10. So it's Title 9, Chapter 10, Article 10 is where you're going to have your primary clinical focus. However, based upon the integration, we have moved many of the definitions over into Article 1. I've not copied Article 1 for you today. It's going to be important for you to go on the website, pull Article 1 down, and make sure that you have that available to you. If you do nothing more than pull down the definitions, it's going to be important for you because those definitions will apply across the board. So in Article 1, as we look at this, these are all of the sections in Article 1 that you will need to be in compliance with in addition to Article 10. This has a lot of the general information related to your application process, related to architectural review and requirements for architectural review if you're building new facilities or if you're modifying your own facility, all of the fees. What I've highlighted in red here are some changes to Article 1. So if you were used to having Article 1 available to you, these are the changes that have occurred in Article 1, which explains more about the enforcement action under Section 110. The tuberculosis screening is going to be consistent across all provider types, and you'll find that in Article 1. There are some exceptions to tuberculosis screening if it's a high-risk provider type that we've put within the rules, but this is the general requirement. Then you're going to see the integration component with the behavioral health professionals and behavioral health technicians in here. The nutrition and feeding assistant training program, which relates to skilled nursing facilities. Probably won't relate to you all unless you want to know what skilled nursing facilities are responsible in this area from a nutritional perspective if you're taking patients from that environment into your environment and you have some nutritional dietary challenges. Counseling facilities and collaborative healthcare institutions. So as you can see where the integration has occurred and moved forward, what you would have seen before is behavioral health, the nutritional, and all of that pulled out and moved into separate articles. Emphasizing again the definitions, make sure you're looking at Article 1 for definitions. You're looking at, and this should say Article 10, I apologize for that, instead of Article 2. Article 2 is the hospitals, so you're going to want to pay attention to Article 10 unless you're a dialysis facility providing dialysis within a hospital. Then you're going to want to be aware of Article 2. And then the Arizona Revised Statutes also have definitions. And remember, the statutes are the law, and you'll find those in ARS 36 in the 400, which is the first part of the 400 section of the revised statutes. And those definitions are not going to be repeated in your articles. So when you're looking at a definition of where you're going to find what's the interpretation of this word, then you're going to have to step back to your own article, which would be Article 10, to Article 1, to the statutes. So you may also want to print off those definitions out of the statutes and have those connected with your rules. Now this is Article 10, which is what we're going to focus on today. And Article 10 has changed significantly. As you can see, and again in red are the changes that we have applied. And this, again, talks about definitions, your supplemental application, all the way down through some of your general functions. And when we talk about this, the sections 1001 through 1010 are all sections that you're going to need to be in compliance with, in addition to your 1018, which is your dialysis services. Okay? Then the next three areas that you're going to need to be in compliance with are infection control, emergency and safety standards, and the physical plant environment. So these in red, so you've got those on your front page of your rules there, so you can see that then again from Article 1001 down through 1010, and then 1028 through 1029, 1030, and then Section 1018. All of those you are going to need to be in compliance with if you're providing dialysis services only. Then what you can do is you can choose to provide any services on this list if you would choose to do so. So if you want to begin to provide emergency room services in your dialysis facility, you could do this. This is what was chosen to be a menu selection for outpatient treatment centers to provide services for. What I heard yesterday was no one really wants to probably expand beyond dialysis services, but it does give you that opportunity. So let's start going through these sections. And we look at 1002, which is the supplemental application. So when we look at that, you know, we're talking about, you'll see in the rules there are references to statutes. Some of the statutes I have pulled over for you to have available so you can kind of see how that is formatted in. In other areas, why we're going to just go ahead and let you do that. And these statutes, again, are identified in your rules. So if you look in your rule packages and you look for the first section, R910, 1002, you're going to be able to find that. R910, 1001 are your definitions. So I didn't include those in here at this point in time. So what I've highlighted in blue during this presentation are things that we want to point out to you that may be new to you or may have been indicated in our review of our data that you have not been in compliance with. This first area is that when you apply for an initial license, you'll submit a supplemental application. Some of you may do this independently within your own organization, or you may have others who assist you with that. But what you're going to need to include in that are your days and hours of clinical operation, and then the days and hours of administrative operation. And this is new because some facilities will be only open certain days and hours for their clinical operations, but may be open additional days and hours from an administrative perspective, which means that your administrative team may be there, but you're not providing services to patients. So that's a little bit different than what it's been in the past. And then you're going to request what services you want to provide. And again, it's the listing of all the services that you have on the front page there of your rules, and you'll go down through and choose which of these services you're going to provide. And for you, it's going to be dialysis services. Do any of you have clinical lab? Do you have a laboratory within your facilities or a pharmacy within your facilities? No. So you probably won't need to get involved with either of those, but some provider groups are now, with the Affordable Care Act and some other opportunities within the evolution of healthcare, are looking at providing some of those services internally. So as you look at that, and if your organization would happen to change that you're going to start providing those services, you would need to be in compliance with those sections as well. So then when we go on to the next section, which is R910003, which is section 1003, we look at administration. And this first section is related to single group licensing and refers over to a statute 36422F or G. And I don't believe we have any dialysis facilities now that are single group licensed under a hospital. And what this means is the hospital's governing authority is the governing authority of this entity and is single group licensed under that governing authority, which means you're an outpatient treatment center functioning under the hospital's license. And that means that you will be surveyed under the outpatient treatment rules and regulations as it relates to dialysis services. And you will need to be in compliance with those in order for the hospital to maintain in compliance with their rules and regulations. I don't believe there's anyone here. You are a department of your hospital, though.
We have one that's under a single group.
Not dialysis, though, right?
No, dialysis.
Oh, it is dialysis. Is that the Glendale one?
Yeah.
Oh, okay. So this does apply to you then. So make sure that you have the statute and you understand what's happening, and these rules then are going to apply to them as an organization. I'd forgotten that. Thank you. So these are all of the components related to that. There's limitations to how many you can have, where they can be located from your facility, and what happens with that. But since we only have one, and I think we're okay with that one, we'll skip through this. Again, I will point out, though, when you look at definitions and you review the statutes, there are definitions embedded in each of the statutes. And this is an example of that, where we have the single group license statute there, but there are definitions at the end of that statute that talks about what is an accredited definition and what is a satellite facility. So definitions are key in order to be in compliance. Okay, then if we move on to B under the administration, we have here that you will establish in writing an outpatient treatment center's scope of services, qualifications for an administrator. So we will no longer determine what administrator qualifications are across all of our provider types. You will be making that determination. You're going to designate an administrator in writing that's established by the governing board is one of the changes that were made, and adopt a quality management program according to what we'll talk about in R910-1004. Review and evaluate the effectiveness of the quality management program every 12 hours. Now keep in mind, as we go back up, you have to reference up, this is the governing authority's accountability and responsibility. So when you look to your governing authority, make sure that your governing authority understands these are their responsibilities. I don't believe we have any governing authorities attending the session today, but you want to make sure you give this feedback back, because when there is non-compliance, the governing authority will be the individual who's held accountable for these. Okay, then if we go on to number 6, expected, if an administrator, the acting administrator, is not expected to be present on the premises for more than 30 calendar days, or is not present on an outpatient treatment center's premises for more than 30 days, then, and except as provided in the statute, you will appoint an administrator. And here's the statute related to that, as well as you will inform the department as to who that administrator is. So if you have an administrator that's designated as the administrator of your facility, and also the administrator of multiple facilities, which can happen, and you can have an administrator of multiple facilities, that administrator needs to be present on your premises at least once every 30 days. If that administrator is not present at least once every 30 days, then there needs to be another administrator designated. Okay? And you need to keep the department informed as to who that administrator is. So that's the governing authority. Now we go into an administrator. The administrator is directly accountable to the governing authority, and except as provided in section B7, and you'll see a lot of references back to the previous rules and regulations so that there's consistency. An individual who's available and accountable for the operation of the outpatient treatment center when the administrator is not available. So when the administrator is not on the premise, there has to be someone else designated to be that go-to person during those operating hours. Okay? Now, if you designate in writing the qualifications of an administrator in your policies and procedures, that go-to person needs to meet those requirements. Okay? Then the administrator has the responsibility for policies and procedures. So when you look at policies and procedures, and as we go through those today, you're going to find that they're broken down into 3 areas. One is the administrative policies and procedures, one is your clinical services policies and procedures, and then the other is the insurance and the responsibility that they're available and implemented within your organization to those who need to implement those policies and procedures. So it talks about the policies and procedures are established, documented, and implemented. And those are the 3 key words: established, documented, and implemented. So you can have them documented, you can have them established, but if they're not implemented, we're going to hold you accountable to those policies and procedures, so they need to be implemented. Included in this are your job descriptions, your duties and qualifications of your staff, including all the required skills, knowledge, education, and experience of your personnel members, your employees, your volunteers, and students. If you have any students, you also need to include that. You need to cover your orientation and in-service education, how the personnel members may submit a complaint regarding the services provided to a patient. So you need to have that as a policy and procedure. Cover cardiopulmonary resuscitation, the method and content that you're requiring as an organization for CPR, the qualifications for an individual to provide that training. If you do it internally, what's that individual's qualifications? If you contract for someone externally, what are the qualifications you expect that person to have? And documentation that verifies that you've received the CPR training that you've identified. And then cover first aid training. And cover first aid training, I believe, is something new for your dialysis facilities that you've not had before. So some of your cardiopulmonary resuscitation, if you're contracting with an organization, may also include first aid training, and some do not. But it will be identified on their cards if it does include first aid training. If not, you can do your own separate first aid training and also define what that means within your organization. Include a method to identify a patient to ensure the patient receives the services ordered to a patient. How are you identifying patients prior to providing the services, anytime during the services if the services are interrupted, and also identifying at the time of discharge that you're discharging the patient, instructions are according to the correct patient. Cover patient rights, including assisting patients who do not speak English or who have physical or other disabilities. Healthcare directives, medical records, including the electronic medical record, and cover quality management, including the incident report and supporting documentation related to incident reporting, and contracted services. So as you can see, these are all the administrative issues that need to have policies and procedures in. You can see on your Excel checklist, you can go through and you can check those off if you're in compliance or non-compliance, and then you can focus on where you need to focus to be able to have completed policies and procedures related to those expectations. Remember, having the policy documented doesn't necessarily mean implemented. So remember, it's three components. It's established, documented, and implemented. So you need to have a process in place that really demonstrates that you are implementing those procedures. Your policies and procedures for services is the next section, and you're going to cover patient screening, admission, assessment, transfer, discharge planning, and discharge. And we'll talk about some of those specifically later when we get into some other sections that relate to transfer, transport, and discharge planning. Cover provision of medical services, nursing services, health-related services, and any ancillary services. Again, it doesn't spell out what you need for those clinical services. You need to determine what policies and procedures you need to have to ensure that your scope of services is being processed appropriately according to your governing authority and your administrative policies and procedures. General consent and informed consent, and obtaining, administering, and storing and disposing of medications, including the provision of controlling inventory and preventing diversion of controlled substances. Cover infection control, telemedicine if you have telemedicine, cover environmental services, and cover specific steps and deadlines for a patient to file a complaint, an outpatient treatment center to respond to the complaint. So again, the expectation is a patient can file a complaint. You're going to have policies and procedures of how you're going to respond, and if applicable, to obtain documentation of employee or volunteers' fingerprinting. And here's the statute related to that. And I'm not sure that any of you in the room would have to have fingerprinting in relationship to dialysis. But here is the statute. You can go and you can print it off and review that and make sure that you're covering that. Looking at smoking and the use of tobacco products, what is your policy and procedure for that? And how personnel members will respond to a patient's sudden, intense, out of control behavior. And I know in our dialysis facilities, based on the reports that I get in, that this does occur in the dialysis facilities. And so you need a policy and procedure. How are you going to respond to a patient who has a sudden behavioral change within your facility? What resources do you have available? And how are you referring that individual out for resources? How are you involving your medical staff? And what additional clinical support can you get from a behavioral perspective for that individual? Just making a decision to discharge that individual from your service is not acceptable. You need to be able to work with that patient. There may be times where you need to discharge that patient from your service, but you have to be able to demonstrate that you have made an effort to get the patient the resources that they need to have in order to control that behavior. Outpatient treatment center policies and procedures are reviewed at least every 2 years and updated as needed. So it doesn't mean necessarily that you only update every 2 years. It's update as needed. So if you change a scope of service, if you delete a service, you may want to pull those policies and procedures. If you're doing, perhaps you're doing PD and you decide you're not going to do it anymore, you're going to want to pull those policies and procedures related to that and change your scope of service. Available to personnel members and employees. Available doesn't mean it has to be hard copy. It can be available by electronic as long as everyone has access to those policies and procedures. What cannot happen is that they be in somebody's office and the office is locked and the staff do not have access to them. This is just a summary of the administrative policies and procedures that you require. We covered each and every one of those. As you can see, I put it here because I want you to realize it is a long list. We understand it is a long list. In the survey process, we're not going to go through and just say, do you have this procedure, do you have this, do you have this, do you have this? Again, that's a change in the survey process. We won't go through and check through that. We may do that on an initial survey so that you have a good foundation, that you understand these are the ones that you need to have in place. However, on a routine survey, we're not going to go through and do a check mark on all of these policies and procedures to see if you have them. We will work backwards, though, if we observe during an observation that medications aren't being administered appropriately, or that the patient rights aren't being maintained appropriately, or that you've got infection control problems. We're going to go back to your policies and procedures. This, again, just emphasizes once every 2 years and available to your personnel. Then we'll go on to number 4, and it says, unless otherwise stated, documentation required by this article is provided to the department within 2 hours. So this used to be 4 hours. It's now 2 hours. So make sure there are some exceptions, and we'll talk about that later on. But in general, all of your documentation needs to be provided to the department within 2 hours. Please talk with the surveyors if for some reason there's some kind of sentinel situation that does not allow those documents to be provided within 2 hours, that you're conversing with the surveyor and they're understanding why that's not available. You know, we certainly were going to be able to work with you on that. But again, this goes back to consistency across the board. And in other of our provider agencies, it was required to be 2 hours. We were being very lenient, so it was determined that 2 hours is fairly reasonable to be able to have documents available, because you should already be doing all of this information, having your policies and procedures, your quality management programs, and all of your quality controls available. Then the following are conspicuously posted: your current license of the department. So make sure that you have your current license. It should be the original license posted in your main lobby where the majority of your public comes in and sees. The name and address, telephone number of the department, and a notice that a patient may file a complaint. And all of that needs to be conspicuously posted. A schedule of your rates, again referencing back to statute, which is the law. A notice that the schedule of the rates are required is available upon request. And so here, if you look in 36.436.01, it's going to give you the actual law that requires that to be posted and made available to individuals who may ask for that. A list of patient rights. A map for evacuating the facility. And again, it references another statute, 36.425D, and it talks about the inspections, the issuance of the license as it relates to all of this information. It talks about your initial license period. Patient follow-up instructions. Patient follow-up instructions are provided orally or in written form to a patient or patient's representative before a patient leaves the outpatient treatment center, unless the patient leaves against a personnel member's advice. So this is after each of your treatments, that you orally give them follow-up instructions, or you give them written follow-up instructions to the patient or to whoever is that person's representative. And you document in the patient's record those follow-up instructions. If abuse, neglect, or exploitation of a patient is alleged, you must follow the statutes, which are the law. And the statutes are 46.454 and 13.3620. 46.454 relates to the adult, And this could be an adult individual who is what you would suspect as a vulnerable adult that comes to your facility, perhaps that have signs or symptoms of abuse outside of your facility, or you are suspecting abuse within your facility in some way, or neglect. So you have, by law, an obligation to report for an adult to the Adult Protective Services or to the public police department. Okay? Then for children is the 133620, and you have that accountability to report for a child. And I know some of you do children. I don't know if anybody's here today doing children, but that would be the same for children. So make sure that you have that. And then if abuse or neglect is suspected to occur on the premise, the following must occur. You need to take immediate action to stop the alleged or suspected abuse, neglect, or exploitation. And you need to immediately report that to the appropriate agency. Again, referring back to the adult goes to Adult Protective Services or the local authority police, or for children it goes to Child Protective Services or the local authority. You can do either or. The law allows you either or. And I know yesterday we had a discussion as it relates to, do you get a report? And we know at this point in time, if you notify the police agency within your local authority, that those police will make a report number and provide that number to you, and you do have access to those reports. Adult Protective Services does a similar component, and they will also provide that to you. However, it may be provided to you at a later date than what the police report will be provided to you. So documentation of this action needs to be maintained for at least 12 months after the date of the report. And the investigation of this suspected or alleged abuse, neglect, or exploitation, and keep in mind it is abuse, neglect, or exploitation. Develop a written report of the investigation within 48 hours of the report that's required, that would include the dates, times, and description, the description of any injury to the patient, names of witnesses, the action taken by the administrator or those of you who are on staff to prevent the abuse, neglect from occurring in the future. And then you submit a copy of that investigation report to the department in 10 working days after submitting the report in subsection F2. Okay? Maintain a copy of the investigation report required for 12 months after the date of the report. Keep in mind, this report is related to those that you suspect having had abuse, neglect, or exploitation on your premise. If you have an individual coming in that you suspect there is something that has occurred outside of your premise, perhaps in their living situation, whether it be an assisted living, a skilled nursing facility, or if it happens to be their own home, then you also, have an obligation to report that, but you don't have to go through the formal report. Okay? Quality management, R910-10-004. This is a plan must be established, documented, and implemented again. Remember, established, documented, and implemented. Those are the three key words for your policies and procedures, your quality plan, your infection control plan. And at a minimum includes a method to identify, document, and evaluate incidents, a method to collect data to evaluate your services provided. So if you have a scope of services, make sure that you're evaluating all of those scopes of services and not just one or two. A method to evaluate the data collected to identify a concern. So the intent of a quality management program is to collect data to seek out opportunities for you to improve your delivery of care within your organization. A method to make changes or take action resulted from your identification, and the frequency of submitting a documented report in subsection 2 to the governing authority. So your quality plan needs to include all of those components. Keep in mind your governing authority, if you remember back up into the governing authority, accountability, and responsibility, the governing authority is responsible for the development of quality management plan. So you're reporting back. They're delegating to you to implement that quality management plan. You're reporting back to the governing authority what your quality management plan is stating. And then your governing authority needs to give you feedback whether that's acceptable service delivery, or are there opportunities, or if they agree with your action plans or want to modify those action plans. Then that documented report is submitted to the governing authority and includes the following: an identification of each concern about the delivery of service, a change made or action taken, and then this report is maintained for 12 months after the date of the report is submitted. And then here's a summary as it relates to your quality. Again, the plan's established, documented, implemented, and ongoing. A plan includes the elements of identification, documentation, and evaluating incidents, collecting data, evaluating that data, making changes, taking action, and identifying the frequency of submitting to the governing authority. Contracted services. Contracted services relates to any services that you have contracts for in providing services that have an impact on the delivery of care within your organization. So you need to have a documented list of contracted services that's maintained and includes a description of those services provided. So you want to make sure that you've got a description of each of those services that are provided of those areas that you contract for. You may have a laboratory contract, you may have a radiology contract, you may have a housekeeping service contract that is involved with your infection control program. You know, so you want to make sure that you've got those services identified and are integrated into that compliance of that section. Moving on to 10.06, which is section on personnel. In personnel, you need to have the qualifications, skills, and knowledge required for each personnel member documented. As you remember, before we talked about job descriptions and the identification of the skills and the knowledge that you needed to have documented in the job descriptions. Now you need to have personnel members' skills and knowledge documented. This is the definition of a personnel member, and it includes a staff member, an individual providing physical health services or behavioral health services. So essentially it's everyone that you have in your employment that you would need to have this provided for. And that is based on the type of physical health services. Again, goes back to your scope of services. So if you list that you're doing home hemo, or you list that you're doing PD, you know, then you need to have appropriate identification of what personnel are being trained in order to be able to provide those services. Or if you're doing in-house ESRD services, then you need to have that list of individuals. Needs to be according to your job descriptions, what your expectations are. And I've underlined here the acuity of patients. And this is key. We don't say that you have to have an acuity plan. We don't say that you have to have a formal process for determining acuity. But if you have certain patients that require more attention, either professionally or technically, than other patients, you need to take that into consideration when you're developing your job descriptions. If you have that individual who has behavioral problems, what kind of training, skills, and knowledge have you provided to your staff to be able to meet the needs of that individual patient? So keep that in mind as to where you're going. Sometimes it's age specific, sometimes it's because patients have disabilities, or maybe a patient's blind. Make sure that you're looking at acuity and how are you training and identifying the skills and knowledge to be able to take care of those individuals. The type and duration of education and experience. This next section talks about education and experience. So what is your education in order to provide the functions that you've set out, and what experience do you have to have in order to be able to perform those skills, again, based upon your scope of services. Then all of those personnel skills and knowledge are to be verified and documented. Before the personnel provides physical health services or behavioral health services, before they provide. So they have to meet what you've identified within your policies and procedures, the skills and knowledge based upon what you've identified as the experience and education before they provide services. That does not mean that they can't be working with a preceptor. What that means is they can't independently provide those services. Personnel members are present on the outpatient premises with the qualifications, skills, and knowledge necessary to provide services in the outpatient treatment center scope of services to meet the needs of the patient and ensure health and safety of the patient. So if you have certain patients in your facility and you only have a small group of individuals who are skilled to be able to meet the needs of that individual patient, then you need to make sure that those individuals are on site, on the premises, in order to meet the needs. A plan's developed and documented and implemented to provide orientation. So in this, orientation means not only orientation to your general organizational policies and procedures as to what your personnel policies are, your health benefits and components related to that, vacation time, hours of work. It also means orientation to the clinical environment and the clinical services that that individual is going to be provided based upon their scope of services that they're going to be accountable and responsible for. And that each personnel member completes orientation, again, before providing medical services, nursing services, or health-related services. And the orientation is documented. That includes the name, date, subject, or topics of that orientation. A plan is developed, documented, and implemented to provide in-service education. So you have orientation, which is the beginning of the services, and then you have in-service education. And the in-service education is documented with the name, date, subject, or topics. And then we're not going to go through behavioral health technicians at this point in time because you won't have those at this point in time, or paraprofessionals. And then a record of personnel member, employees, or volunteers, or students is maintained that includes. And some of our providers were challenged with the word student. Do any of you have students in your facilities? If you have students then, and I see some nods, that you would need to have at least some documentation from that educational agency that includes at minimum the following areas that we're going to talk about, which is the name, date of birth, home address, and contact telephone number, the starting date of employment or volunteer services, and the ending date. And documentation of those individuals' qualifications, including the skills and knowledge, the education and experience, and the individual's completed orientation and in-service education as required in the policies and procedures. The individual's license or certification, if appropriate, and then the behavioral health we won't need to go through. And again, this is an example of the statute. And then the fingerprinting, if it's required by the statute, and your cardiopulmonary resuscitation. And then the record is maintained while an individual provides services for at least 2 years after the last date of the employee or volunteer's provided services. And if the ending date of the employment or volunteer has 12 or more months before the date the department requests, you'll have 72 hours to provide that documentation. All right, I think this is a good stopping point for a break. So I think we'll stop and we'll go ahead and give you a stretch break. We'll take about 10 minutes. So, all right, we're going to start now with transport and transfer. And this is new for dialysis as you look at your previous rules. And the definition for transport is defined in Article 1. This is an example where you'll find that in Article 1 under R910, Section 101, 191. So what transport means is sending a patient to another healthcare institution for outpatient services with the intent of returning the patient to the sending institution, or returning a patient to a sending licensed healthcare institution after the patient has received outpatient services. Okay, so that's what transport means. And when you look at transport requirements, it states that a personnel member coordinates the transport and services provided to the patient. Remember, personnel member is anyone within the dialysis center. According to policies and procedures, an evaluation of the patient is conducted before and after transport. So according to those policies and procedures, that you are doing an assessment or an evaluation of that individual. Medical records are provided to the receiving facility. And a personnel member explains the risks and benefits of the transport to the patient and or the patient's representative. Documentation in the patient's medical record includes the communication with the individual at the receiving healthcare institution, the date and time of the transport, the mode of transportation, and the personnel member accompanying the patient during the transport, if applicable. So go back and look at the definition. So when you look at the definition of transport, it talks about the individual patient is leaving your facility with the intent to return after perhaps an outpatient service is provided, or returning a patient to a sending licensed healthcare institution after a patient received outpatient services. So a licensed healthcare institution could be a skilled facility, so your skilled nursing facilities. It could be an assisted living facility. So think about how you're complying with this when you are having a patient that comes in for outpatient services and then is being transported back to a licensed entity. You need to follow these regulations. Then we move into transfer. And the definition of transfer is discharging a patient and sending the patient to another licensed healthcare institution as an inpatient or resident without intending that the patient be returned to the sending healthcare institution. So this is where you're transferring a patient. So if you're transferring a patient, and you're transferring that patient to another healthcare institution as an inpatient, as an inpatient, or resident without intending to be returned to the sending institution. Okay? And then the same general requirements are required. A personnel member coordinates the transfer. An evaluation of the patient is conducted before the transfer. Medical records, including the orders that are in effect at the time of the transfer. And you're responsible for explaining the risks and benefits of the transfer. And then, of course, documentation of all the communication with the individual at the receiving facility, the date and time of the transfer, the mode of transportation, and the personnel accompanying that patient during the transfer if it's applicable. Okay, section 1008 is patient rights. These requirements relate to what we talked about earlier with the governing authority and the administrator having policies and procedures and identification of patient rights. So if you go back to the administration and the governing authority, those need to be conspicuously posted on the premises. And at the time of admission, a patient or the patient's representative receives a written copy of the requirements in subsection B and the patient rights in subsection C. And we'll get to B and C. Remember, on admission, they receive the patient rights. The policies and procedures include how and when a patient or a patient's representative is informed of those rights, where the patient rights are posted. So here you have your policies and procedures for patient rights. The administrator shall ensure that a patient is treated with dignity, respect, and consideration, and a patient is not subjected to the listing that we have here, which is abuse, neglect, exploitation, coercion, manipulation, sexual abuse, and seclusion. Restraint, if it's not necessary to prevent imminent harm to self or others. Retaliation for submitting a complaint, or misappropriation of personal or private property. So make sure, I know that your patients bring in personal property, so make sure that you have an appropriate space, location, and protection of that personal property. A patient or patient's representative either consents or refuses treatment, which is a patient right, may refuse or withdraw consent, and then except in an emergency is informed of alternatives to a proposed psychotropic medication or surgical procedure and associated risks and possible complications to the proposed medication or surgical procedure. Now, in your facilities, you're not being a behavioral health facility, you do not generally on routine give psychotropic medications. But if you have a patient that you have a one-time order for, or you get a verbal order because of a behavioral outburst of a psychotropic medication, you have to follow this requirement. So a psychotropic medication is defined in your rules in the Article 1, and it means a chemical substance that crosses the blood-brain barrier and acts primarily on the central nervous system where it affects brain function, resulting in alterations in perception, mood, consciousness, cognition, and behavior that is provided to a patient to address the patient's behavioral health issue. So that encompasses a significant amount of medications that we have today. So you may have some of those one-time medications that you're going to need to be aware of and understand that you'll need to meet this requirement, okay? Is informed of the following: the outpatient treatment center's policy on healthcare directives, the patient complaint process, and consents to photograph of the patient before the patient is photographed, except when you're photographing individual patients for identification. And some providers are beginning to photograph patients and putting it on the medical record, and that is okay to do. You might want to inform the patient that that's what you're doing and that's how it's being used. But if you photograph the patient for any other reason, you do need to have consent. And then, except as otherwise permitted by law, you have a written consent for the release of the patient's medical records or financial records. Many times you have that in your general consent form. And a patient has the following rights: not to be discriminated against based upon race, national origin, religion, gender, sexual orientation, age, disability, marital status, or diagnosis. To receive treatment that supports and respects the patient's individuality, choices, strengths, and abilities. So keep in mind, you may have individual patients that have their own choices, whether it be an ethical choice, cultural choice, or whatever that may be, that you do need to respect those choices. Receive privacy in the treatment of care or personal needs. And to review upon written request the patient's own medical record according to the statutes. And this is important. The patient has a right to review their own medical record. It is the law that they have the ability to do that. I have copied the law here. We won't go through it in detail, but just to show you that it is very extensive as it relates to what the law says about, and you may want to attach this into your own policies and procedures or integrate the law into your policies and procedures. This gives you a guide for the development of those. And it's the release of the medical record, and then the other one is the release for medical records and payment records. Quite extensive, and you'll see a lot of the content relates to all types of healthcare facilities and not just certainly the outpatient facilities. Then continuing on with the patient rights, they have the right to receive a referral to another healthcare institution if the outpatient center is unable to provide the physical health services or behavioral health services that the patient is required to have. To participate or have the patient's representative participate in the development of or decisions concerning treatment. And to participate or refuse to participate in research or experimental treatment. To receive assistance from family member or representative or other individual understanding, protecting, or exercising the patient's rights. So again, for the policies and procedures, you have to have how and when the patient's representative is informed and where the patient rights are going to be posted. And then we move on to the next section, which is 1009 medical records. And again, you're going to have a reference back to statute, ARS Title 12, Chapter 13, Article 7.1, which gives the significantly in this statute I did not copy and bring over to its full extent because a lot of the rules that you're going to be hearing about in this section are included in that law. But again, you still may want to go back and reference it to be sure you're all inclusive. An entry in a patient's medical record is recorded only by personnel member authorized by the policies and procedures to make entry, dated, legible, and authenticated, not changed to make the initial entry illegible. An order is dated when the order is entered into the patient's medical record, includes the time of the order. It's authenticated by a medical practitioner or behavioral health professional according to the policies and procedures. And if the order is a verbal order, authenticated by the medical practitioner or the health professional issuing the order. Key component, if it's a verbal order, it needs to be authenticated by the individual practitioner who has issued that verbal order. Rubber stamp signature or electronic signature code is the responsibility of the individual who that code or rubber stamp represents. And a patient's medical record is available to all members and according to your policies and procedures. Information in the medical record is disclosed to an individual not authorized under the section A5 only with the written consent of the individual patient or patient representative. Policies and procedures include a maximum time frame to retrieve the patient's medical record. So you need to have your policies and procedures that state how long does it take for you to retrieve a medical record. A patient's medical record is protected from loss, damage, or unauthorized use. If an outpatient treatment center maintains a patient's medical record electronically, then the administrator shall ensure that the safeguards exist to prevent unauthorized access. The date and time of the entry in a patient's medical record is recorded by the computer's internal clock. And the medical record contains the patient information that includes the patient's name and address, except as specified in the statute. You can go in and look at R96-1005 in the statute, but I summarized here it really relates to the HIV testing. The patient's date of birth, the name and contact information of the patient's representative, any known allergies, including the medication allergies, a diagnosis or reason for outpatient services, and the documentation of general consent and, if applicable, informed consent. And general consent definition and informed consent definitions are found back in Article 1. And in Article 1, general consent means documentation of an agreement from an individual or individual's representative to receive physical health services to address the individual's medical condition or behavioral health services to address the individual's behavioral health issues. So that's your general consent. Informed consent is also found in Article 1, and the 97 means the number in Article 1 that you'll find it. It'll be 101.97. Informed consent means advising a patient of a proposed treatment, surgical procedure, psychotropic drug, or diagnostic procedure, alternatives to treatment, surgical procedure, psychotropic drug, there's duplication in here, we'll change that, associated risks and possible complications, and obtaining documented authorization for the proposed treatment, surgical procedure, psychotropic drug, or diagnostic procedure from the patient or the patient's representative. So look at your informed consent, what your policies and procedures say today, and does it include all of this information related to your patients? Documentation of medical history, and if applicable, the results of physical examinations, your orders, assessment, treatment plans. Interval notes is also a new term that you will have. An interval note is also defined in R910-101.99. And an interval note means documenting and updating a medical condition after a history and physical examination is performed or a behavioral health assessment. And the interval note is generally completed by the medical practitioner, and a progress note is also defined in 101.147, and that means documentation by a medical staff member, nurse, or personnel member of observed patient responses, a patient's significant change, observed behavior of the patient related to the patient's medical condition or behavioral health issue. So many of you will use progress notes across the board, and that's okay. You don't have to change your terminology in your policies and procedures. You can continue to use progress notes across the board, but the distinction is in the difference between the interval note being made in your history and physical, if you're updating that, and then the progress notes, the ongoing documentation of the care and delivery that all members within your institution are providing. Documentation of an outpatient treatment center services provided to the patient, so any services you provide should be documented. Name of each individual providing the treatment or the diagnostic procedure, the disposition, the follow-up instructions, a discharge summary, and the discharge summary is also defined in Article 1, number 66, and states means a documented brief review of services provided to a patient, current patient status, and reasons of the patient's discharge. And then, if applicable, laboratory reports, radiology reports, sleep disorder, diagnostic reports, documentation of restraint or seclusion, which you generally do not do, and consultation reports. Documentation of a medication administration that includes the date and time, name, strength, dosage, and route. Medication administered for pain must have an assessment before and assessment after to determine the effect of the medication. Same for the psychotropic medication. You need to have an assessment before and the effect documented after the administration. Must include the identification, signature, and professional designation of the individual administering or observing in self-administration if you do self-administration. And you may assist with self-administration maybe in your home dialysis programs, and we'll talk about that a little bit later. Adverse reactions. Pre-packed or sampled medications, you need to have the name, strength, dosage, amount, route of administration, and the expiration date. And in your medical records, as it relates to your policies and procedures, you have to have the policies and procedures, the time frames to receive a patient's medical record at their request, and a patient's medical record is protected from loss, damage, or authorized use. You're going to see now as we go through some of the components of medication services and some of the discharge and some of the safety issues, some things that you've identified already that go across with the medical record component. But the medical record really is the documentation of what you have stated that you have provided to the individuals within your facilities. So you're going to see some repeats here in medication services as it establishes what you're going to be doing with medication administration. Your policies and procedures are established, a process for providing information to a patient about the medication prescribed, the prescribed medication's anticipated results, potential adverse reactions, potential side effects, and potential adverse reactions. So what this means, when you administer a medication to a patient, you need to describe to them what you're giving, why are you giving it, and what the potential adverse effects of that medication will be. Procedures for preventing, responding to, and reporting a medication error, an adverse response to a medication overdose. Procedures to ensure that a patient's medication regime is reviewed by a medical practitioner and meets the patient's needs. Procedures for documenting medication services and the assistance in self-administration. Procedures for assisting a patient in obtaining medication. So if you're giving them a prescription, how are they going to obtain it? And if applicable, procedures for providing medication administration or assistance in self-administration of the medication off the premises. Specify a process for review through the quality management program. Your medication administration services need to be a key component of your quality management program. A medication administration error, an adverse reaction to a medication. And if, as at the outpatient treatment center, you provide medication administration, you need policies and procedures for that and reviewed by the medical staff practitioner. Specify the individuals who can order medication and administer medication. So back in your personnel, when you identify your job descriptions, you may want to include, if you have other than the licensed individuals administering medications, you may want to include what the skill, experience, and education of those individuals are to be able to do that. A patient's refusal to take a prescribed medication, and verbal orders for medication services are taken by a nurse unless otherwise provided by law. So any of your verbal orders need to be taken by a nurse. And a medication administered to a patient is administered in compliance with an order and documented in the patient's medical record. Key here for the dialysis facilities, the administration must be in compliance with an order. So your physicians have orders, some of them you have standing orders that you apply, making sure that you have a process in place that ensures that implementation of those medication orders are done according to what the medical staff member has written. A pain medication is administered to a patient. Documentation in the patient's medical record records, again, the before and after. As you saw in the medical record, it requires that. Now you're seeing in the medication administration process the same requirement. And then in self-administration, you need to have documentation that the patient's medication is stored by the outpatient treatment center. When it's stored by the outpatient treatment center, that the following assistance is provided to a patient: a reminder when it's time to take the medication, opening the medication container for the patient, observing the patient while the patient removes the medication from the container, and verifying that the medication is taken is ordered by the physician or the medical practitioner, and confirming that the patient taking the medication is the individual stated on the container, no sharing of medications among patients. The dosage of the medication is the same as stated on the medication container, and the medication is being taken by the patient at the time stated on the medication container. Observing the patient while the patient takes the medication is a key component of self-administration. Policies and procedures for assistance in the self-administration must be documented, and training for the personnel member other than a medical practitioner or a registered nurse on self-administration of medications. So if you have anyone other than a medical practitioner or a nurse monitoring your self-administration, then you need to have documentation of that. And is provided by a medical practitioner or a registered nurse or an individual trained by the medical practitioner. Includes a demonstration of the personnel member's skills and knowledge. So if you're training someone to do self-administration, that you have trained them on the skills and knowledge. Identification of the medication errors and medical emergencies related to self-administration, and the process for notifying the appropriate entities when emergency intervention is needed. A personnel member other than a medical practitioner or registered nurse completes the training in Section C4 before the personnel member provides assistance in self-administration, and assistance with self-administration of the medication is provided to a patient is in compliance with the order and documented in the medical record. It's a lot on self-administration, and it's my understanding that some of you do this process in some of your dialysis centers when it comes to your home dialysis patients. So make sure that you have that integrated into your policies and procedures. Then if we move on, that you must have a current drug reference guide and a toxicology reference guide. This does not have to be a book. It doesn't have to be a manual, but you have to have a resource for your staff as it relates to drug references and toxicology references. I don't believe any of you said you had pharmacies on site, so we won't go over the statutes related to the pharmacy. However, when a medication is stored in your out-treatment center, you need to have a separate room, closet, or self-contained unit used for medication storage that includes a lockable door. And the medication is stored in a room or a closet. There is a locked cabinet that is used for medication storage. Medication is stored according to the instructions on the medication container. Policies and procedures are established for receiving, storing, inventorying, tracking, dispensing, and discarding medications, including expired medications. Discarding or returning prepackaged and sample medications to the manufacturer and manufacturer's request the discard or return of the medication. A medication recall and notification of patients who receive the recall medication. And then again, the storing, inventorying, and dispensing of controlled substances. And if you recall earlier, under the governing authority and administration, it talked about some of these policies and procedures as well. An administrator shall ensure that a personnel member immediately reports a medication error or a patient's adverse reaction to a medication to a medical practitioner
who ordered the medication, and if applicable, the outpatient treatment center's clinical director. And immediately is defined in our rules under Article 1. So it is there, and it means immediately. And we won't go through behavioral health services, and this is a long list here, so we'll scan through this. There's quite a few pages that you'll be able to go through. We'll go down to R9, 10, 18. And 1018 is, of course, where your primary scope of services are located. Keep in mind, these are put in here for your review because if you would decide you want to do a behavioral health services arm to your clinic, you can do that under state licensing. The same with clinical lab services, crisis intervention, diagnostic imaging. Now we get down to Section 1018, which is your dialysis services. And keep in mind, these regulations have not really changed. They were moved from your article that you currently had, which was an independent article for facility outpatient treatment centers doing dialysis, nursing, and medical services. You will see now in this section, though, there are some additional definitions. So in addition to the statute definitions, Article 1 definitions, and then Article 10 definitions, you've got in your section now some definitions that apply. And most of those are you're very similar with which is caregiver, means an individual designated by a patient or a patient's representative to perform self-dialysis. And because they're defined here in this article, these definitions, they're not used in any of the other articles in the healthcare providers. So that's why it's very specific to dialysis services. You also use the terminology as chief clinical officer, and that means a physician appointed to provide direction for dialysis services provided within the outpatient treatment center. And then, of course, the dialysis definition, which we don't need to go through for you all. And then dialysis services and what that means. Then you have the long-term care plan, which I know you all really do not want to get rid of because you like it so much. And it means a written plan of action for a patient with kidney failure that is developed to achieve long-term optimum patient outcomes. We are in discussion, I will let you know right up front that we are in discussion as to whether we will continue with this requirement or not. This will be discussed and evaluated over time between October and March. But this is one of the rules that we have earmarked at this point in time with the assistance of the surveyors who have identified that perhaps this is not a regulation that we need to have to protect health and safety. So we will be evaluating that over time. But right now, you still need to be in compliance with it and continue to provide that service. Your modality definition means a method of treatment for kidney failure, including transplant, hemodialysis, and peritoneal dialysis. Your nutritional assessment in these guidelines have a specific meaning, which means an analysis of a patient's weight, height, lifestyle, medication mobility, food and fluid intake, and diagnostic procedures to identify conditions and behaviors that indicate whether the patient's nutritional needs are being met. Your patient care plan has a specific definition, which means a written documentation for a patient receiving dialysis that identifies the patient's needs for medical services, nursing services, health-related services, and the process by which the medical services, nursing services, and health-related services will be provided to the patient. So this is going to be real important. If we evaluate the long-term care plan, we're going to need to really look at how comprehensive are your patient care plans. So look at that, see what your policies and procedures are, how are you documenting those patient care plans, and can that encompass what was originally required in the long-term care plan. Peritoneal dialysis means the process of using the peritoneal cavity. You all know that. Psychosocial evaluation means the analysis of an individual's mental and social conditions. Reprocessing means the cleaning, sterilizing a dialyzer previously used by a patient. Self-dialysis means dialysis performed by a patient or caregiver. And here's a definition of stable. And this is important because as we go on with some of the rules and regulations, the definition stable is used in some of the other rules. It means a patient's blood pressure, temperature, pulse, respirations, and diagnostic procedure results are within medically recognized acceptable ranges, or consistent with patient's usual medical condition so that the medical intervention is not indicated. So when you're developing your policies and procedures and looking at the implementation of those and looking at the care and services that your individual patients have, and you're following the stable guidelines, make sure that they're meeting this definition along with your own policies and procedures. Transplant surgeon, we won't go through that definition, but it is in your rules for your reference. And then it goes into the governing authority, and we're going back to governing authority within this section, ensures that the administrator is appointed, required in R910, section 1003B3, has at least 12 months of experience in an outpatient treatment center providing dialysis services. So if you recall, when we were back in administration, we talked about there's no specific requirements for the administrator in the overall general rules across the applicability across all outpatient treatment centers. But for dialysis, it was determined from a health and safety perspective, the person who's giving the leadership direction within your organization needs to have dialysis experience at a minimum of 12 months. So that would need to be incorporated into your policies and procedures and your definition and job descriptions of an administrator. Appoint a chief clinical officer to direct the dialysis services provided, who's a physician, who is board eligible or board certified in internal medicine or pediatrics by a professional credentialing board, and has at least 12 months of experience or training providing dialysis. And again, this is important for you to understand so that if you have physician turnover, that when new physician comes in, as your chief clinical officer, do they meet those requirements? Then as we go through the rest of these dialysis rules, they're very similar to what you have and currently are accountable for. So we're not going to spend time today going through that. I did pull across for you so you can see that there is a law related to your hemodialysis technicians and your trainees, and it's in the Arizona Revised Statute 36423, and then reference back into Article 1, which is R910-113, and then this is the statute that talks about the requirements related to the hemodialysis technicians and trainees. Again, an example of where the statute's developed, which is the law, moving into rule under R910, Article 1, and then moving into your specific service component that you're delivering. And then I pulled over the R910-113, which has the clinical practice restrictions of the hemodialysis trainees and all of the requirements. And most of you are very familiar with this. But remember, it's a way when you look at these rules to make sure that you're pulling over all the references so that you understand what the law says, what the rule says, and the reference rules require. don't think we need to go through all, you all understand that, right? And then here, it again emphasizes cardiopulmonary resuscitation. It's felt like it needs to come into the dialysis services because of the high-risk patients that you're providing services to and what you're providing, because you're really providing critical care within your outpatient environment. So this is looked at very significantly, and we understand what you're doing and certainly appreciate what you're doing, and the patients definitely do. So make sure that you do have appropriate cardiopulmonary resuscitation and that those have that before providing services when you've left them independently within your organizations, and then at least every 2 years after the initial date of employment that it's renewed. Then a personnel member wears a name badge that displays the first name, job title, and professional license or certification if applicable. So it needs to have some type of identification, preferably a name badge, but the question has come up, can you use tape on a coat that you're using within the center? You can, as long as that's not covered up, you know, and that a patient can read it and know what it says. A minimum of 1 registered nurse or medical practitioner is on the premises while the patient's receiving services on the premise. And the premise of the outpatient treatment center where dialysis is provided complies with the applicable physical, plant, and health safety codes and standards for outpatients. Now, as you know, that in 2008, state licensed dialysis facilities were required to come into physical plant codes and standards. And if you were already operating and did not make changes to your facility or modify your facility in any way, you are allowed to continue to operate as your facility was originally licensed. Once you make a modification to your facility, add 1 chair or move in some way, then you need to come into compliance, which is the Arizona Administrative Code R91412, which requires an architectural review by your architect with confirmation by the state architect that you are in compliance. What codes and standards you need to be in compliance with are based upon when your permitting is done, which is your local authority permit process to determine the zoning requirements and the local authority requirements. Is the date that that permit's issued is what codes and standards you have to comply with. The importance of that is what I'm saying is because now, as of October 1, there will be new architectural requirements that are changing as well. And those are changing to the Facilities Guideline Institute guidelines, which are for 2010. And I think I have a slide at the end where you can get to those guidelines. The guidelines are available only by viewing. If you want hard copies or print anything, you have to pay for them. But your architects are very well aware of those guidelines and can really guide you in that. So you don't necessarily need to have the manual, but you need to be aware that there are requirements that this rule requires you to be in compliance with as it relates to modifications of your facilities. So before any modification or any facility's initial development, you must submit an application to the department for architectural review and compliance. And that application is found on the website, so you can go on the website and be able to find that application and submit it. It is a different application from what you submit for your renewal license or for your initial license. That's submitted to the department. The department state architects review that application, get with your architect, and follow up with what's codes and standards are applicable to your facility, and then they come to consensus and agreement and move forward and give you the approval to continue with your construction development and the changes that you want to make. I would caution you, do not make changes or modifications, move walls, build walls, or change the usage of a chair for anything internally without communicating with the department, because that can create some issues down the road and create problems with what you're doing within your organization as it relates to construction and modification. And that's what this talks about. Okay, then an administrator shall ensure that for a patient receiving dialysis services, a physician performs a medical history and physical examination on the patient within 30 days before admission or within 48 hours after admission. So again, the medical physician, doesn't say what physician, but a physician needs to perform that history and physical 30 days before admission or within 48 hours after admission. And then that's documented in the medical history and physical examination on the patient's medical record within 48 hours after admission. So if they wait to perform it 48 hours after admission, it needs to be documented right then as well. Let's just talk a little bit about admission, because an admission is to the licensed entity. So that is if a patient comes to you from a facility that is on the east side and comes to you perhaps because you're on the west side because they've moved or relocated, that is a new admission to the licensed entity. So you have to conduct the admission process. Okay? So if that patient's history and physical hadn't been done within 30 days, then you do that history and physical within 48 hours. Remember, it's a new admission to a licensed entity. If it's a patient that's coming to your facility as a vacation, because maybe they live in New Mexico and coming to your facility while they're here on vacation, or they're coming from back east for being over the winter, that's a new admission to your facility. So you have to follow admission processes. When that patient leaves your facility, that's a discharge from your facility. It's not because of the services that's being provided on a continuum basis for the patient. It's a licensed entity, so it's admission and discharge, okay? If the patient's medical history and physical, as required, is not performed by the patient's nephrologist within 30 days after the date of the medical history and physical examination reviews and authenticates the medical history and documents the concurrence with the medical history and physical examination and includes information specific to nephrology. If the history and physical that was done by another physician did not talk about nephrology, then you need to ensure that when your nephrologist is documenting, which in most cases, because that's their specialty, they're going to document that. But we have found cases where they just say concur with the history and physical, and then there's still not any nephrology documentation incorporated into that. Or performs a history and physical examination that includes nephrology. So there's an option there. The patient's nephrologist or nephrologist designee performs a medical history and physical examination on the patient at least once every 12 months from the date of the patient's admission. This is the nephrologist then again, every 12 months. And documents monthly notes. A registered nurse responsible for nursing services reviews the patient reviews with the patient the results of any diagnostic tests, assesses the patient's medical condition before the patient begins receiving hemodialysis, and after the patient has received hemodialysis. The key here is assessing. Assess the patient's medical condition before and after. If the patient returns to another healthcare institution after receiving dialysis services, provides an oral or written notice of information related to the patient's medical condition or the registered nurse responsible for the nursing services, or if there is not a registered nurse responsible, the person responsible for the medical services or health services within that healthcare institution. Informs the patient's nephrologist of any changes in the patient's medical condition. And this is an area where we're seeing, unfortunately, I would say fairly significant noncompliance. So when the patient's condition changes during dialysis, the physician does need to be notified. So I would certainly emphasize this as you move forward with evaluating your services. Documents in the patient's medical record any notice provided as required in the section, any monthly notes related to the patient's progress, and if the patient is unstable, remember we had the definition of stable. Now any patient that is outside of that definition would be considered unstable. And if the patient is unstable before dialysis is provided, a nephrologist is notified of the patient's medical condition, and dialysis is not provided until the nephrologist provides direction. So it doesn't have to be the patient's nephrologist, it says a nephrologist. And then the patient's under the care of a nephrologist. We don't see problems with that. That's been a rule. You're in compliance with that in general. Then receives the dialysis services ordered for the patient by the medical practitioner. Remember, the medical practitioner's orders are what has to be implemented unless you call the medical practitioner and get a change in those orders. The patient is monitored by the personnel member while receiving dialysis at least every 30 minutes. And if the outpatient treatment center reprocesses or reuses dialyzers, is informed that the outpatient treatment center reprocesses and reuses dialyzers before beginning hemodialysis. And that should also be documented. Equipment used for hemodialysis is inspected, tested according to the manufacturer's recommendations or the outpatient treatment center's policies and procedures before being used to provide hemodialysis to a patient. Keep in mind the manufacturer's requirements and guidelines must be met at a minimum. If you want to exceed those guidelines, you can in your own policies and procedures. But you must at minimum meet the manufacturer's guidelines. The equipment inspection and testing required in subsection E8 is documented. And then if the hemodialysis is provided to a patient, a personnel member inspects the dialyzer before the use to ensure all of the components are appropriate, and you all know each of those. And ensures that a patient's vascular access is visible to a personnel member during dialysis. And I've underlined this because we have recently started to see that patients are covering up their access and staff are allowing that to occur. So please be watching what's happening within your centers and making sure as a nurse and as a technician you are accountable for that. So you want to make sure that you always have visual view of that access. A patient receiving dialysis is visible to a nurse at a location used by nurses to coordinate patients and treatment. And then after a patient's discharge from an outpatient treatment center, the nephrologist responsible for the dialysis services provided to the patient, documents the patient's discharge in the patient's medical record within 30 days. A description of the patient's medical condition and the dialysis services provided to the patient, and the signature of the nephrologist are what's included in that. This is not delegated to a nurse to do. This is a nephrologist's responsibility to document the patient's discharge in the patient's medical record within 30 days with a description of the patient's medical condition and the dialysis services provided to the patient with the signature of the nephrologist. Okay? And I put in here the definition of a discharge summary for you, which means a documented brief review of services provided to a patient, current patient status, and reasons for the patient's discharge. If an outpatient treatment center provides support for self-dialysis services, administrators shall ensure that a patient or the patient's caregiver is instructed to use the equipment to perform monitoring in the patient's home to assess the patient's ability or the patient's caregiver's ability, instruction provided to the patient as required is documented in the patient's medical record, and then they have the supplies and the equipment necessary to do the self-dialysis, and the water that's used for the hemodialysis is tested and treated according to the requirements. Then, of course, your documentation of your self-dialysis is maintained by the patient or the patient's caregiver, is reviewed to ensure the patient is receiving continuity of care, and placed in the patient's medical record. And then it gets into the self-administration of medications, and that the medical practitioner is responsible to provide medical staff practitioner responsible for dialysis services provided to the patient, reviews the patient's diagnostic laboratory tests and make sure that that practitioner is doing that, and that the patient and the patient's caregiver are informed of any side effects or hazards to a child having access to medications when they're doing that in the home. And the patient or the patient caregiver is taught the route and technique of administration, taught to be able to perform sterile procedures, techniques, and provided with instructions for the administration of the medication, able to read and understand the medication, able to self-monitor the patient's blood pressure, and informed how to store medications according to the manufacturer's instructions. And I think most of you do a very good job with your home dialysis, but just keep in mind that these are the steps that you need to go back and review. An outpatient treatment center will ensure that the social worker is employed by the outpatient treatment center to meet the needs of the patients receiving dialysis services, with them conducting initial psychosocial evaluations of the patient within 30 days, and then the continued on recommendations of participating with identifying the patient's needs, making recommendations, assisting the patient in identifying community agencies and resources, documenting monthly notes, and conducting a follow-up psychosocial evaluation at least once every 12 months. And then the same for a registered dietitian is employed, and they conduct an initial nutritional assessment of the patient within 30 days. They're also consulting and providing advice in relationship to their assessments, monitoring the patient's adherence to response to a prescribed diet, reviewing the diagnostic tests that relate to nutritional and dietetic needs, monitoring, documenting monthly notes, and conducting a follow-up nutritional assessment on the patient at least every 12 months. So your social worker and your dietitian is every 12 months and need to be integrated into your team. And then we have the long-term care plan for each patient, in which the chief clinical officer, and we have the definition of a chief clinical officer, must be involved along with a nephrologist if the chief clinical officer is not a nephrologist, transplant surgeon, a registered nurse who's responsible for the nursing services provided to the patient, social worker, registered dietitian, and the patient or the patient's representative. And the purpose of that is to identify the modality of treatment, that the modality is reviewed and approved by the chief clinical officer, signed and dated by each personnel. It includes documentation signed by the patient or the patient's representative and signed by the patient, reviewed at least every 12 months. And again, as I said, we are evaluating the value of this regulation. So we hope as our data collection goes on over the next few months that this may be one of the rules that we seriously look at as to whether it's adding to the health and safety of the patients. Then the administrator of an outpatient treatment center providing dialysis service shall ensure that a patient care plan for each patient is developed by a team, which includes at least the patient's nephrologist, registered nurse, social worker, registered dietitian, and the patient or the patient's representative. So your patient care plan reviews should include all of those individuals, which would include an assessment and identification of the treatment and the treatment goals, signed and dated by each personnel member. Signed and dated by each personnel member includes the documentation that's signed and dated by the patient and is implemented and is evaluated by the registered nurse, the registered dietitian, and the social worker on an ongoing basis to see that the patient needs are being met. And then this is reviewed and updated according to the needs of the patient at least every 6 months for a patient whose medical condition is stable. We go back to the definition of stable. And then at least every 30 days for a patient whose medical condition is not stable. So the rest of this hasn't changed any as we move forward with that. The only thing that I've highlighted here is that within 30 days after the patient's discharge, there is discharge documentation that includes the description of the patient's medical condition and the signature by the nephrologist, which is we talked about with the discharge summary. And then that you follow your guidelines that we've documented, which you all have been aware of that and been required to do that. And that the chief clinical officer ensures the quality of the water used in dialysis. The chief clinical officer, as you know, we've described what that means, is accountable for the quality of the water. And you need to be communicating with that chief clinical officer whenever there are any levels that are out of range. And then the outpatient treatment center where dialysis services are provided complies with the applicable physical, plant, and health and safety code standards, which you talked about, again, references into R91412. So that's your dialysis services. Now we're going to go past emergency services because you're not providing those services. My mouse is tired here. Yeah, we're going to go down to infection control, which is section 1028. And this will be the last 3 areas that are going to be required for you unless you choose to do any of these other optional areas. And if you do, let us know and we'll help you walk through those. Okay, 1028, section 1028 is infection control. I will identify that in dialysis services we're finding some general non-compliance with infection control. So please pay attention to this and walk through this. as you go back and you look at your operations within your facility. An infection control program is established under the direction of an individual qualified according to the outpatient treatment center's policies and procedures to prevent the development and transmission of infections and communicable disease. This is an area where you need to have someone identified as your infection control preventionist or have that responsibility within your facility. And this is an example where you would want your job descriptions to represent that this person has that additional skill and knowledge to be able to represent you all within the organization to be able to function in that role. A method to identify and document infections, analysis of the types, causes, and spread of infections and communicable diseases. And that's for employees as well as patients. You know, what are you doing with your employees as well, you know, with what their sickness or their illness may be and how they present care to individual patients. The development of corrective measures to minimize or prevent the spread, and documentation of infection control activities including, and this is prescriptive as to what you need to include in infection control. And again, this becomes more prescriptive because it is defined as a health and safety risk. So the department has determined that this needs to be a little more prescriptive, but it also gives you some latitude. The collection and analysis of infection control data, the actions taken related to infections and communicable diseases, reports of communicable diseases, and infection control documentation is maintained at least 2 years. And then you're following the statute in Arizona Administrative Code 6 for reporting and control of measures for communicable diseases. Your handling of your biohazards, isolation, sterilization, use of PPE is being followed and managed appropriately. Your cleaning, hand washing is managed and followed, and you've got work restrictions for a personnel member and employee. Your biohazards are followed according to, again, a reference to statute. And a personnel member or employee volunteer washes his or her hands with soap and water or uses hand disinfection product before and after each patient contact and after handling soiled linen, soiled clothing, and potential infectious material. An administrator shall comply with the contagious disease reporting requirements. So small but mighty rule set. So make sure you're going back and you're looking at how are you in compliance with the infection control components. Section 1029 is emergency and safety standards. And this is where an administrator will ensure that policies and procedures for providing emergency treatment are established, documented, and implemented. Again, the 3 words, established, documented, and implemented. A list of medications and supplies and equipment required on the premise for emergency treatment. It's not prescriptive. It's for you to define what medications, what supplies do you need to have available in your center to be able to treat an emergency condition. A system to ensure medications, supplies, and equipment are available and have not been tampered with. A requirement that a cart or a container is available for emergency treatment that contains medication, supplies, and equipment specified in the outpatient treatment center's policies and procedures. Does not define that you have to have a certain cart or a certain bag or a certain location. You need to define that within your own policies and procedures. And a method to verify and document that the contents of the cart or container are available for emergency treatment. And emergency treatment is provided to a patient admitted to the outpatient center according to your policies and procedures. And then next is a disaster plan. So a disaster plan is developed, documented, and maintained in a location accessible to personnel members. In that plan, you need to have procedures for protecting the health and safety of patients on the premise. And keep in mind, you may need to shelter in place for a while. So what are your shelter in place requirements? Do you have food, water? Do you have the ability to maintain individual patients in your facility for a period of time if patients cannot go home? And also evacuation processes. If you need to evacuate, what do you do if you don't have water supply, you don't have power supply? What are your procedures and policies as it relates to that? We have power outages very frequently in Arizona, so what do you do if you're in the middle of a treatment? How do you manage that? What do you do as it relates to the responsibilities of all personnel? Instructions for evacuation. Arrangements to provide medical services and nursing services to meet the needs during disaster management. And your plans reviewed at least every 12 months. And that you conduct an evacuation drill on each shift at least every 12 months. So if you run 4 shifts, then you need to have an evacuation drill on each of those shifts at least once every 12 months. A disaster plan is reviewed as required and documents the date and time of an evacuation drill, the name of each personnel member, employee, or volunteer, a critique of the evacuation drill, and if applicable, recommendations for improvement. So each of those would be documented. So if you have 4 shifts, you would have 4 documents each year that describe each of those evacuation processes and what action you've taken to improve. And your documentation is maintained for 12 months after the date of the evacuation drill or disaster plan review. And an evacuation path is conspicuously posted in each hallway. Both of the following are tested and serviced at least every 12 months. So this is your fire alarm system and your sprinkler system. So those need to be tested at least every 12 months. And then your smoke detectors are installed in each hallway of the outpatient treatment center. And if that can be either battery operated or if hardwired into the electrical system, there needs to be a battery backup. And then, of course, tested monthly. Then you need a portable, operable fire extinguisher. And then you need people who know how to use it on the premise. And it gives you some examples of that. And then you need to have documentation of a test required for all the testing that you're doing. You need documentation of that. It needs to be maintained 12 months after the date. You have to have illuminated exit signs, and they need to be illuminated. Not the capability of illumination, but they also need to be illuminated. And a corridor in the outpatient treatment center is 44 inches wide. Corridors and exits are kept clear of any obstructions. And a patient can exit through any exit during the hours of operation. And an extension cord is not used instead of permanent electrical wiring. And the electrical outlet and electrical switch has a cover plate that is in good repair. And you need a sign placed at the entrance of a room or an area indicating oxygen's in use. And oxygen and medical gas containers are maintained and secured in an upright position and stored in a room with a door. And then if you have a building with sprinklers at least 5 feet away from the combustible materials, and in a building without sprinklers at least 20 feet away from combustible materials. Then section 1030 is the physical plant environmental services and equipment standards. And I don't really have a lot highlighted in here because I think that most all of you are meeting these at this point in time. So I would just encourage you to go through these, look at these, make sure that you're in compliance with all of these. We made it through all of the rules. I want to thank you all for coming. We'll have time, we have about 20 minutes for questions and any comments and thoughts.